Hello, everybody, and welcome to the second webinar of the Helios Speaker Series. Helios is a EU-funded project by the Cost Action, and it runs for 4 years from September 2023 until 27. And whilst the main focus is on Europe, we have members from all over the world, and at the moment we have over 200 members. Helios funds networking, training, mentorship, and conference attendance opportunities. And just very briefly, our activities are focused on research coordination and capacity building activities. From a research coordination point of view, working groups 1 to 3 identify needs, harmonize procedures and protocols, and then also promote multi-center data-driven research. Working group 2 then monitors the implementation and reviews new treatment options, whereas working group 5 disseminates the knowledge created. From a capacity building point of view, Working Group 4 promotes young researchers, women and ethnic minorities, and also develops a European training program. Working Group 1 promotes the use of new technologies for diagnosis and research, and Working Groups 4 to 5 promote cross-sectoral dialogue. Working Groups 1, 2, and 3 are generally sort of focused on knowledge creation, which is then transferred by Working Groups 4 and 5. And the Helios leadership team is comprised of many well-known experts in the field of hemoglobinopathy, such as Dr. Barbara Nusa, Dr. Andreas Quentoy, Dr. Raffaella Colombatti, Dr. Petrus Kontouris, and many others. And the Helios Speaker Series runs every month, with our next speakers being Kristen Howell and Anueska. If you want to sign up for these webinars as well, you have to register for each webinar individually. On our website, you also have a link to past recordings of past webinars. At the moment, we only have one webinar so far with Dr. Oyesola Oyewunmi, who's spoken about the impact of the fetal hemoglobin on the severity in sickle cell disease. And today we are delighted to welcome Professor Sophie Lanzkron. Professor Lanzkron is a professor in medicine and the division director of hematology at the Sidney Kimmel Medical College of Thomas Jefferson University. She is internationally well known for her pioneering research on the optimal care and management of patients with sickle cell disease. And after reading the 2020 National Academies of Sciences, Engineering and Medicine consensus report on sickle cell disease, which found lack of data to characterize sickle cell disease specific disease burden, outcomes, and unmet needs, Professor Sophie Lanzkron and her team were motivated to perform a pilot study with the goal to implement standardized data collection tools. Professor Lanzkron will talk about this pilot study today. So let me give you a warm welcome to Professor Sophie Lanzkron, and over to you and your presentation. Thank you very much.
Thank you very much, Stephanie, for that introduction. I'm going to share my slides. See them? Yes? Great.
Yes.
Okay, so you heard what I'm going to talk about. So just a few of my disclosures. Well, these are my disclosures. I've been asked to talk a little bit about how I got in this space. I'll spend a little bit talking about me, not my favorite subject, then talk a little bit about sickle cell disease, the burden of the disease, and then as measured by our work, and then sort of some of the implications, I think, the take homes of our work. So why do I do this work? I fell in love with hematology during my 4th year of medical school during a hematology elective when we were looking at smears, and the fellow ran in. He was so excited, and there was a smear, and there was microangiopathic hemolytic anemia, and there was a case of TTP, and he was so excited. And it was so easy, right? You take a good history, you look at a smear which costs 20 cents to make, and you make a diagnosis, and it was simple, and right, you waste your time sort of doing a lot of other things. The patient dies, you got to act quickly, you got to do things. And so there was a lot of excitement and a lot of fun, and I love looking at blood smears. And then I wasn't smart enough to be a family practice doc or GP because they need to know everything. And so sickle cell disease was a really nice niche for me. It gave me the opportunity to follow patients over many, many years, which is great. There was one drug when I started, which made life really, really simple and straightforward. But also sickle cell disease affects every organ, as I'll show you in a minute. And that part of understanding pathophysiology is fun and important and keeps me on my toes and keeps me thinking, which I really enjoy about medicine. And then the other thing I enjoy about medicine are my colleagues. And people who do this work are awesome people, right? They want to take care of underserved community and population of people living with the disease. And they're fun to hang out with. And you get to meet a red cell that walks down the street at ASH. So that's why I'm doing the things that I'm doing. I often start my talks when I talk about sickle cell disease with this quote that is from the New England Journal of Medicine, written by our colleagues, Dr. Powers, Hayes, and McGann. There may be no population of patients whose healthcare and outcomes are more affected by racism than those with sickle cell disease. And it's one thing to say it, but there's another one. There's sort of evidence to back it up. And I could put 3 or 4 slides after this with evidence to back it up. But this is one from a paper we did looking at resources that are allocated for people with sickle cell disease in the US versus those same sort of resources allocated to people with cystic fibrosis. So in the US, there are about 90 to 100,000 people living with sickle cell disease. There are about 30,000 people living with cystic fibrosis. So I'm sure you're well aware it affects a very different looking population, right? So 1 in 314 Black people versus the patient population impacted by cystic fibrosis are typically Caucasian. And so that probably plays a role here. And then when you look, the main funding source in the United States for research is the National Institutes of Health. And when you look at funding from the National Institutes of Health over the course of a year, it's about $76 million for people with sickle cell disease and $84 million for people with cystic fibrosis. And, sounds like those are kind of similar numbers, but when you break it down by person impacted by the disease, it's about $812 for every person with sickle cell disease and almost $3,000 for every person with cystic fibrosis. And then when you look at foundation funding, so these are the folks who can fund your social worker or your research coordinator or have a fellowship program to train additional physicians to do the work. The Cystic Fibrosis Foundation, which is just an amazing organization here in the US and generates millions of dollars, 231 to be exact a year, which is an outrageous amount of money to have, compared to the Sickle Cell Disease Association of America, which raises barely $10 million. And when you look at it per person, that's $102 for every person with sickle cell disease and almost $8,000 for every person with cystic fibrosis. And this all matters, right? This matters for research funding to make things better for our patients. This matters to make sure that we have the infrastructure to take care of our patients, which includes having social workers and community health workers and all of those parts that foundations can fund. When you don't have those resources, it's really hard to provide patients with the same level of care that our colleagues can provide for people with cystic fibrosis in this country. So a little bit about sickle cell anemia, probably everyone is very familiar, but just to make sure everybody's on the same page, single base substitution of a valine for glutamine for the gene encoding for the beta globin chain affects, as I mentioned, about 100,000 Americans. It still decreases life expectancy by 25 to 30 years, and I'll show you a little bit of that data. We used to think there were 3 or 4 distinct origins of the gene mutation in Africa 3,000 years ago, but a paper that came out in 2018 suggested that this happened once 7,000 years ago. And I like to talk to patients about this fact that the gene mutation happened maybe once 7,000 years ago, right? One baby was born with this mutation, and that baby didn't die of malaria. And so they went on to have more children, and then that person had more children, right? So you can get malaria, but you're not less likely to die from malaria. And sickle trait to this day is probably the thing that preserves more lives from malaria than anything else that we have to offer people who are impacted by malaria. And so when you think about the impact of this gene mutation on how many lives it has saved over 7,000 years, it's sort of astronomical to think of it that way. This gene mutation was brilliant for where it happened. It saved lots of lives. Unfortunately, if you have 2 of these gene mutations, your life is shortened and it's a problem. But it's fascinating, and I like telling patients about it, right? There's so much stigma associated with sickle cell disease, but in fact, this gene mutation is really important. So, right, the gene mutation we're talking about is in the hemoglobin molecule, which is made up of 2 alpha chains and 2 beta chains. It is normal to have this hydrophobic pocket. It's not normal to have a valine sticking out. And so under the right clinical conditions, the hemoglobin molecules stick together and form a polymer. This is what happens to your red cell. So in A is a normal red cell, normal biconcave disc, and then you get the development of polymers, and the kinetics are that once the polymer starts, it begins to grow, and you end up with a cell that looks like E, which is either breaks apart in the vascular space or is removed by the reticuloendothelial system. This picture never works on Zoom, but it's a cool picture I took off the web years ago, showing rigid red cells getting stuck in the microvasculature, which is what we used to think was the cause of vaso-occlusive events, right? Rigid red cells, areas distal to the obstruction weren't getting oxygen, not getting blood, and you ended up with pain. We now know that the development of vaso-occlusive crisis is much more complex than just stiff red cells. There's increased expression of adhesion molecules, both on the endothelial surface as well as on the red cells. So you have these stress reticulocytes that are very sticky. And so it happens that there's an occlusion. We still don't understand what the first step is in this event, but we have some understanding, and some of the disease-modifying therapies are working around this idea of increased adhesion molecule expression. Regardless of what the underlying pathophysiology is, this is what it looks like. I take care of adults, but I always show this picture of a baby. This is a baby 4 to 6 months of age, first episode of a vaso-occlusive event, dactylitis, swollen hands, swollen feet. Nobody's sending the baby home saying, this is not real, right? This baby has real manifestations of the disease, probably suffering significantly, and gets taken care of appropriately. And I show this picture because I like the people who maybe are awoken at 2 o'clock in the morning because they're getting an admission from the emergency room of a patient with sickle cell disease who has no objective measure, but that this is what's going on in the background is a really important thing for them to remember as they would like to put their head down on the pillow, so that they hopefully more likely to treat the patient with respect in those situations. So I talked about the first consequence of the polymerization of the hemoglobin molecule and those stiff red cells. The second is that you get this intravascular hemolysis, which about 30% of all of the hemolysis occurs in the vascular space. Our protective mechanism of scooping up all this free hemoglobin is overwhelmed by how much hemolysis there is. And so you end up having consumption of nitric oxide and low levels of nitric oxide. Nitric oxide is really important for vascular hemostasis. You need it to decrease pulmonary artery pressures, to inhibit platelet aggregation. It's a vasodilator, and it also helps decrease adhesion molecule expression. So all of these consequences lead to the disease manifestations that I mentioned, right? Sickle cell disease affects every organ in the body. And so you need to have some understanding of this if you're taking care of the patient population, but you can see why the burden of the disease and the expense of the disease could potentially is quite significant. Just sort of going back to our lack of success here and some of the barriers that we face. This is some data on sickle cell disease and mortality in the United States. We expect just about every child born with sickle cell disease in this country to make it to adulthood. The numbers are somewhere between 96 and 98%. In 2014, most of the deaths occurred in the young adult, middle age sort of group, 25 to 54. But our CDC, Center for Disease Control, started a surveillance program, not in every state, because that would be silly, just in a few states. Right now, I think it's 11 states, maybe 17 states. But in California and Georgia, they have a good surveillance system, so they can capture everybody who lives in the state with sickle cell disease. And what they demonstrated is that the mean age of death for women is 43 years and 41 years for men, which means we haven't changed the needle in overall survival for people living with the disease. So there's so much to do, right, to overcome some of the barriers. And as Stephanie mentioned, the NASEM, which is the National Academies of Science, Engineering, and Medicine, had a consensus report that was published in 2020 that found that there was really a lack of data that characterizes the disease burden and outcomes, especially with the modern patient living with sickle cell disease. So there was no longitudinal cohort of people living with sickle cell disease. The last one was from the cooperative study, and that study ended in the early 1990s. And so we have no longitudinal natural history information on the modern patient living with sickle cell disease. And I didn't put a slide in here, but a few of us got together and said this was not good, crazy. In 2015, we started to build another natural history collection tool called Granddad, which is a registry that's now available in IRB approved in 72 places across the US. And we've actually partnered with Kate Gardner in the UK also, who has taken part of our Granddad registry and is able to use it there to help us collect the data we need to describe the modern patient living with sickle cell disease. And the purpose of this study was this, looking at the feasibility of collecting the data to estimate illness burden, using Granddad, our registry, as sort of the basis for doing that. And then to investigate the factors associated with health-related quality of life in sickle cell disease, and then to estimate the societal burden, including direct and indirect costs. So just a little bit of background on quality of life in sickle cell disease. There is not a ton of data in adults, but there have been a number of studies done in pediatrics looking at health-related quality of life. And this graph or table at the top is from a meta-analysis that was done looking at all of the health-related quality of life in the pediatric population. And you can see here, like all of the lines are on the sickle cell side, demonstrating that that children with sickle cell disease have lower levels of health-related quality of life compared to controls on almost every aspect of the disease. And in particularly, people who have more disease severity have worse health-related quality of life, not surprisingly. And some suggestion that disease-modifying therapy might modulate that health-related quality of life, and that people who are on disease-modifying therapy might have better health-related quality of life. There are papers here and there with some similar results from sort of single-centered studies looking at adults, but has not been a robust examination of this across many sites for adults in particular with sickle cell disease. And then just looking at the economic burden, again, not a whole lot of data out there on the economic burden of sickle cell disease. This is actually from a paper from 2009, so it's old, but probably hasn't changed very much, kind of like the mortality data. And the economic burden in the United States was estimated at more than $1 billion a year spent on this population, which corresponded to about $16,000 per patient per year. And in this graph, you can see where most of these costs are. First, they're mostly in the adult population, particularly those between the ages of 30 and 39. The blue represents hospital-related costs, so these are hospitalizations. And the red is ED visits, and you can't even really see the green, which is outpatient visits. So most of the costs are from acute care utilization for this patient population. So the methods that we used were, we took two sickle cell, this was a pilot study, remember, so this is two sickle cell centers located, one on the eastern part of the country, one on the western part of the country, so Maryland and California. To enroll patients, sort of consecutive patients, convenient sample patients into the study. It should be noted that our center in Baltimore, which enrolled the majority of the patients, had an infusion clinic to help decrease hospital admissions. And so I think you'll see some of that reflected in the data that I show. We enrolled people from July of 2019 through August of 2020. Adults, any type of sickle cell disease, were able to be enrolled, and the baseline data, everybody was enrolled in this study as well as into the Granddad registry, so we could pull their phenotypic type data out of the registry as we wanted. The most important part of the study were the tools that we used to sort of survey burden and economic costs. And so we used Ask Me, which is a validated tool for people with sickle cell disease looking at health-related quality of life, and it has 7 domains: emotional impact, pain impact, sleep impact, social functioning, stiffness impact, and pain episodes. And then the final one is this medical history checklist, and I'll talk a little bit about that. So except for the medical history checklist, all of these scores are standardized to a T-score. And the T-score has a mean of 50 plus or minus 10 for its standard deviation. And the score of 50 represents the average health-related quality of life of the benchmark population in which the tool was developed in. So in a population of people who are living with sickle cell disease, 50 was the average. So that's the T-score to keep in mind. The higher domains represent a more favorable status for emotional, pain, sleep, social functioning, and stiffness. But lower domain score are more favorable for pain episode frequency and pain episode severity score. So you just have to keep that in mind, that some higher ones mean better health-related quality of life and some lower ones mean lower quality of life. And then the medical history checklist is a 9-item checklist basically of sickle cell disease related complications, and it's scored based on quartiles and of the distribution of the scores. We also use the EQ5D3L, which is the three-level version of the EQ5D, which was developed by the Euroqual group. I'm sure you're all very more familiar with it than I was. It consists of two scales, really, the EQ5D index and the EQ visual analog scale. So the index comprises 5 dimensions of health-related quality of life: mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. Each of these have 3 levels: no problems, some problems, extreme problems. You can get a score of 1, 1, 1, 1, 1 if you have no problems in any of these, and 5, 5, 5, 5, 5 if you have severe problems in all of these, and some mixture of these depending on how you score in each one of these levels. And then the EQ the visual analog scale captures respondents' overall assessment of their health status, from 0 being the worst possible health to 100 being the best possible health you can imagine. We also used PROMIS short forms. I'm not sure you're all familiar. I hope people who do this kind of work are probably very familiar with the PROMIS tools. These are validated tools that can look at many, many different aspects of patient-reported outcomes. And we used the 4A fatigue scale. And again, the higher PROMIS is also T-score, represents more of the concept being measured. So a T-score of 60 is 1 standard deviation worse than the average. So a higher score means that you have more fatigue. We used the GAD-7, the standardized anxiety score, and a PHQ-8, which is the standard depression screening tool. And then finally, we asked patients a single question of, do you experience pain on 3 or more days with a week in the past 6 months, to represent whether or not they have chronic pain or not. For the direct costs, thankfully, a really good partner at USC who helps figure out how you measure these costs. We looked at annual healthcare utilization data obtained from the patient's chart review. So someone went through and count how many different ED visits, how many infusion clinic visits, how many hospitalizations each patient had. We looked at length of stay and the primary diagnosis, which were used to calculate inpatient costs. Direct sickle cell related health costs were determined by multiplying the measure units of healthcare utilization by the representative unit price associated with each service. Treatments, so it's important to know that treatments outside of the patient's designated treatment center were not necessarily captured because they weren't necessarily in our electronic health record. Inpatient cost was estimated on the basis of the mean costs associated with the diagnosis of sickle cell disease with crisis, because that was the majority of diagnosis codes, and that data is available through one of the federal agencies, the AHRQ, National Inpatient Sample. In addition to the inpatient costs, we looked at the outpatient utilization, so doctor visits and ED visits, and we used MEPS, which is another sort of governmental way of estimating those costs. Outpatient or doctor visits included all their annual multidisciplinary comprehensive visits. It also included infusion center visits. So if they came in for acute care for their management of their sickle cell disease, that was considered an outpatient visit. Physical therapy, social work, psychology, all the outpatient stuff. And all of the direct costs were summed from their outpatient visits, their ED visits, and their hospitalizations. For indirect costs, these were imputed using a human capital approach. So productivity loss was measured in terms of lost earnings, using wages as a proxy measure for the output of work time. We included lost wages from missed work for employed participants and lost wages due to working part-time or being unemployed because of sickle cell disease. Missed work days were calculated from the WPAI, which is a specific health problem patient service. So it captures how many days of work did you miss because you were ill. The average hourly earnings were based on 2018 and was $27.1 an hour. And the total costs included both the direct and indirect costs. And they were all represented in 2018 costs. We used descriptive analyses mostly. There was some Pearson correlations and student t-tests to look at differences between groups, which I'll show you in a moment. So again, pilot study, so only 32 people who were enrolled. All of them were over the age of 18. Mean age was 36.7 years. Majority of them were female. Half of the sample reported working in a job or a business in the week before taking the survey. 50% had completed a four-year college degree or higher. 31% earned $25,000 or less annual household income. 84% of the participants were Black or African American. Most of them had insurance. 2 states in this country where insurance was readily available, so they were covered. And important to note, 81% of the participants reported having chronic pain, which is higher than what has been reported in prior studies. But in a study we had done across 4 states, kind of close to what we're seeing in our adult population. 90% of the participants used prescription pain medicines to treat the sickle cell disease in the past 6 months. The majority of these patients had hemoglobin SS disease. There was a mixture of some variant disease. 53% of the whole group was on hydroxyurea. The most commonly prescribed drugs, this is the part that makes me want to weep, but the most commonly prescribed drugs were opioids, both short and long acting, and 10% hydroxyurea. Important to note that our disease modifying therapy included a lot of people who were on transfusions, which was not captured here. So when we looked at the health-related quality of life, this is from the EQ-5D VAS and the EQ-5D index. So remember, the VAS is that score from 0 to 100. The blue are the adults with sickle cell disease, and the red is a historical population of people without sickle cell disease between the ages of 35 and 44. And you can see that patients with sickle cell disease had a lower EQ-5D VAS. They also had a lower of that the index score, which was that combination of mobility and anxiety and pain. And so that was also lower in people with sickle cell disease than it was in people without sickle cell disease. The results of the Ask Me score, they were comparable to the mean scores of patients who were in the original benchmark group in which the tool was developed. So the mean fatigue score was 57.9, so a little bit higher than the general population by about 8 points. And then when you look at the health-related quality of life, we stratified it by chronic pain or not having chronic pain. And remember, this is a small sample, and yet we're still able to pick up some of these differences. So the red is people who had chronic pain, and the people where blue is the people who did not have chronic pain. And you can see in all of these aspects, they had higher scores they had lower scores if they had chronic pain compared to the people who didn't have chronic pain, which, right, when you say it is not surprising. But remember what I said, the burden of chronic pain it's really significant. So when we look overall at the impact of chronic pain, patients, again, who had chronic pain had significantly lower mean Ask Me pain and social impact scores. They had higher pain episode frequency and pain severity scores, not surprisingly. And the fatigue score was lower than the participants who did not report having chronic pain. When we looked at the associations between fatigue and hospitalizations, higher fatigue scores were associated with lower EQ-5D index scores and lower Ask Me scores as well. And the number of hospitalization was negatively associated with the health-related quality of life. So the more hospitalizations you had, the lower your health-related quality of life. There was no association with fatigue and hemoglobin level. When we looked at utilizations and costs, you can see that the Up here are in this chart are the number of visits and number of ED visits and hospitalizations. So the mean number of outpatient visits over the course of a year was 14 for this population, with 2 ED visits and 2 hospitalizations and 15 prescriptions over the course of a year. So significant. I mean, I don't know how many of you go to the doctor 14 times a year. It's a significant burden on our patients. And then when you look at the breakdown of costs, what's interesting here is the outpatient costs. So the outpatient costs were about $21,000 compared to the hospitalizations cost, which was $19,000. And if you remember from that slide that I showed early on, historically, and I think it's true in lots of places still, that the costs are often driven by hospitalizations. But the majority of these patients came from a place where we treated folks in our infusion clinic and avoided hospitalizations. And so the driver of lots of the costs here were the outpatient visits. And you can see the mean total medical costs of $44,000, and then adding in the indirect costs about $51,000, and that's represented here. So the total costs is about $50,000 per year for the patient population. Some of the limitations here is the small sample size, obviously. It was a convenient sample. Subjects were treated at comprehensive sickle cell programs. So these are places where they're getting, hopefully, the best possible care available to them. Places that have specialized infusion clinics, and probably does not represent patients who don't have access to those resources. It did not capture utilization outside of the home institution. And these outcomes are only for adults with sickle cell disease and not pediatric population. So in conclusion, some of the important take homes here are there are some outcomes, health-related outcomes that are important to patients, has been demonstrated in the past, things like fatigue, that really negatively impact health-related quality of life. And that sickle cell disease continues to be associated with significant economic burden, largely from direct medical costs through outpatient and infusion visits. Again, different than what has been reported in the past. And then our next steps with this is that we're doing this in 4 different sites instead of just 2 different sites, trying to collect on a larger population of patients to see if our pilot studies are reproducible. And I think, it's been a difficult couple of months for us here in the States, and I'm sure for you guys as well, unrelated to politics, but more to like getting our drugs pulled off the market, right? So voxelotor getting pulled off the market, which was approved in the US based on just the increase in hemoglobin by a gram, despite the fact that they did collect some of these promised tools, including fatigue and health-related quality of life, but were never published. Probably not published because if they'd been positive, they probably would have been published. And so I think this little microcosm reflects an opportunity for us to think about how we move forward with doing studies in the future. I mean, with Criz and Elizumab also hanging by a thread here in the States and pulled off the market there in Europe, right? We've gone backwards, right, way back. And so the question then becomes, right, are we using the right outcomes and endpoints for our patients in order to determine whether or not our therapies are really effective? And so one is we should be doing phase 3 trials on all these drugs before they get approved. And then we really need patient-centered outcomes to help us understand how our therapies work. And so I think this really gives us a great opportunity to think about how we potentially could use some of the tools here to see if they are impacted by therapies. So there unfortunately have not been a lot of studies looking at the AskMe specifically to see if it changes with changes in therapy. I like to talk about our colleagues who take care of folks with rheumatoid arthritis. Since I have time, I'm just going to carry on. But since there are colleagues who take care of folks with rheumatoid arthritis, they've used patient-reported outcomes as primary outcomes in some of their studies, looking at new therapies. And when someone comes to the clinic with rheumatoid arthritis, they fill out these surveys before they see the physician. And the physician uses that as a tool to decide whether or not they need to change therapy. I really think that's where we need to go here, because so much of what we do is subjective. Sure, increasing hemoglobin is great, but if your patients are dying like they were apparently from voxelotor or having more crises, that's a huge problem and probably more important to the patient than whether their hemoglobin went up a gram. And so I'm going to stand on my pulpit here and talk about, I think we need to change our approach to how we think about therapies. And I do think these tools are sensitive, maybe not as sensitive as we would like them to be, but are sensitive to the patient's experience of pain, for sure. So the chronic pain and the fatigue, lessening quality of life are important messages I think we can take from this. And I just want to say thanks to the team. So I am not an expert in economics and health economics, but there is this group that had done work for a long time on hemophilia. And they decided to sort of change gears a little and move their thought to folks with sickle cell disease. And so especially Mike Nickel, who's an amazing health economist who really helped us think through this and helped us interpret the results so we knew what we were talking about. It was just a great team out of USC that was very helpful. And then our other site, the Center for Inherited Blood Disorders in Orange County, as a partner to help us do this work. And with that, I will stop sharing. And I'm happy to answer any questions.
Thank you, Sophie. That was absolutely fantastic. Really, really fascinating to hear about your research. If anyone has any questions, maybe you could either put them in the chat or raise your hand, and then we unmute you to ask the question directly. I'm really curious, to start off with, because you mentioned obviously the experiences of rheumatoid arthritis patients who regularly fill in surveys, and I'm wondering for this particular study, what were the main barriers in terms of sickle cell patients filling in surveys? Do you think there was a high willingness, or what were the general experiences?
So the question is, right, how often do we want them to fill out these services if we really want to look at it? And for this, so standard granddad registry, everybody fills up once a year. But for this, we did at 3, 6, and 12 months, we had patients filling out surveys. And, it took some chasing down of folks, but most of them were willing to put their data in. And so I think as we do a larger study, we will have potentially the opportunity to look at whether or not there was any impact to changes in therapy and how patients were doing.
And I'm also really curious because you mentioned you will do a follow-up study, obviously, with 4 different centers. And I'm curious, do you actually include any non-specialist centers? Because I'm just sort of wondering, because you obviously mentioned that you have an infusion clinic, for example. And so as we know, obviously, that reduces the number of hospitalizations. So I'm kind of curious, do you include any non-specialist centers, or how do you think the results change for different centers?
Yeah, so, the hard part is capturing a patient if you're not at a specialized center. Like, how do you find and identify people with the disease who don't have access? We are really trying very hard. We have a national alliance now of sickle cell centers, really trying to get centers in every part of the country so that everyone will have access to a sickle cell expert, because we all think it really matters. The only other way really to capture at least the utilization data is, these large administrative data sets that have their own set of limitations, but that's a lot of the prior data is built on these administrative data sets where you can look at utilization and then estimate costs. And I think, right, that is the only way to find people who are not in specialized care, and to figure out, what happens to them. But it's very hard to tease out, right? You have to pick parts of the country, right? There's so many different confounders. I think it's hard to capture data from people who are not getting specialized care.
Yeah, I totally agree. Is that, do you think, also one of the main reasons a similar study hasn't been done in pediatric sickle cell patients? Because I guess it's a lot harder to capture their, I suppose, quite subjective feelings about living with this condition.
Yeah, right. It's hard to capture the people who are not in high quality care. And we know, right, that there are lots of kids who aren't getting their TCDs. So we know there are kids who are not getting the comprehensive care that they need. So they're out there. And it's just, how do you find them?
Totally agree. So we got another question from Petros Contouris, who says, thank you, great talk. Regarding the methodology, why did you choose the specific PROM instruments? And then there's a follow-up question, are there any alternatives to consider? And then there's a third follow-up question. And are there some of these instruments applicable to thalassemia syndromes as well?
So a couple of things built into this question. So the Ask Me is sickle cell specific. So this was tested and validated in a population of people living with sickle cell disease. So really no other alternatives, and it has all those different domains. Fatigue is a little bit different. So these PROMIS tools there are tons of them, and they're all validated in the general population, not necessarily generated for people with sickle cell disease, but they are robustly validated. Like they've been used a lot there. There's a level of comfort in using them that we think that they are probably the best instruments out there to measure things like fatigue. There's the PROMIS pain interference, and you can count the number of pain episodes. So they have all of these different PROMIS tools to measure all sorts of patient-reported outcomes. There might be other tools that are out there to measure pain and pain frequency. None of them have been more or less validated than the PROMIS tools, and so there's really no reason not to use the PROMIS tools. They're available, they're free, and they, at least are validated tools. There was a publication, I know Dr. Carroll was on it, looking at patient-reported outcomes that should be used in clinical trials and studies. And that's a published work that you can, I'm sure, Google, that goes through some of the tools and why some of them are beneficial and not. And because the PROMIS tools were sort of globally validated, I think they very well could be used in people who have thalassemia syndromes as well.
Fantastic, very good. I'm just looking if there are any other questions. I cannot see any at the moment, but in case people have any more questions, maybe if they haven't had a chance to read your publication yet, obviously I highly recommend reading it because it's fantastic. How can people get in touch with you in case they have any follow-up questions?
Yeah, they can email me. It's sophie.lanzkron@jefferson.edu. Do you want me to put it in the chat? I can put it in the chat.
Yeah, why don't you put it in the chat? That would be amazing. I mean, maybe also for any other colleagues who weren't able to join today, we also recorded this meeting and we uploaded to a dedicated Helios YouTube channel. So if you kind of want to listen back to this presentation today, or you want to share it with your colleagues who couldn't join today, then feel free to obviously share the link. But yeah, it was absolutely fantastic to have you today, Sophie. Really, really inspiring work. Because as we know, obviously, it's not just about obviously the therapies available. It's a lot about the health economics as well, and really inspiring to hear obviously how you develop these data collection tools. And yeah, we can't wait to hear about the next study with the 4 sensors then.
Well, I really appreciate the invitation, and I think what you're doing with the Helios project is really amazing.
Thank you. All right, everyone. Well, I hope you have a good day. And if you want to join the next webinar, that's with Kristen on the 18th of December. You can go to the heliosaction.eu website and you can find the registration link there. We'd be obviously delighted to have you on our next webinar as well. And thank you very much, everyone, for joining today. And we just got another thank you. Thank you, Sophie, for the presentation. And have a good day.
Thank you all.
Thank you. Take care. Bye-bye.